Hi, I'm Kate Lafferty. This is Step by Step, where we take veterinary practitioners and members of the veterinary care team through important veterinary conditions and issues step by step. This algorithm will cover the whens and whys of using procedural sedation to improve patient care and to achieve better diagnostics. This episode of Step by Step is sponsored by DECRA. Let's start with some context. What is PSA? PSA is something in human medicine that is used very commonly. This stands for Procedural Sedation and Analgesia. And what this is the process of administering varying short-acting sedatives, analgesics, opioids, dissociative agents for patients that are undergoing procedures that could cause anxiety or pain. So what are the reasons to incorporate PSA? Some of the common uses are radiographs, urinary catheter placement, CT, echocardiograms, local blocks, and IV catheter placement. But there are a lot of reasons that end up being a little bit less utilized in our day-to-day veterinary practices. Some of the less utilized uses would be temperament, physical exam, nail trims, and ear cleanings. Some of the benefits of PSA include decreased stress levels for patient and staff, increased safety for both patient and staff, decreased fear and negative associations for both patient and staff, improved diagnostics, and improved efficiency. You have that cat that comes in, that dog that comes in that is so afraid, and they become a risk to themselves and to the staff. And so if you're using appropriate sedation and analgesia for those really frightened patients, you increase the safety level for the patient who's not going to be scared and jump off of a table, or be scared and bite someone, or be scared and hurt themselves. You are also decreasing the stress level of staffing. And I know this personally. This also decreases fear and negative association. So when we have patients that come in for recurrent bandage changes, those patients come in, you sedate them, you give them analgesics, and they don't have that negative association with coming to the veterinary clinic and having something painful happen. And ultimately, using appropriate sedation will increase the efficiency and the quality of your diagnostics. Instead of taking a dog to radiology, holding them down, they wiggle, and you have to take another one, and you have to take another one, and you have to take another one. If you sedate that patient, you're going to get good quality radiographs the first or the second time around. It's taking you less time because you're not having to repeat those radiographs over and over again, and you have better diagnostic quality. So anytime I'm coming up with a sedation protocol, I have to go through a little bit of a pre-planning phase. And what I'm doing in this is identifying what I need in that protocol. So we aren't talking cookie cutter. We are talking about tailoring to each patient within a frame. So some considerations for the patient. We're going to think about temperament, whether they're fractious versus nervous versus just wiggly. We're going to consider coexisting conditions and contraindications, and think about what drugs best serve the patient in these situations. We're also going to consider the procedure. And so I always think about the sedation level. How much sedation is actually needed for this procedure? The duration. How long is this actually going to take? And then I also look at the procedure and consider, is this an appropriate place for sedation? So I take all of those pieces, and that is what I put together when I start coming up with that sedation protocol. And so we get a little nervous when we start calling things protocols because we don't want everyone to have the exact same plan. But I think it's totally appropriate to have a framework that is your protocol that you alter for each patient. So moving to identifying available drug options, I think this is where people start to get really overwhelmed. And this might be a reason that people just choose not to sedate patients, because they look at this list of drugs that they have available and just get completely overwhelmed and decide that it's too much. So what I like to do is go through each of my categories and then decide what is going to be appropriate for the situation. Sedatives that we have available to us include acepromazine, midazolam, dexmedetomidine, Zenalpha, which is the most recently available sedative that we have on the market, and alfaxolone. We also have our opioids. We have butorphanol, buprenorphine, hydromorphone, methadone, and fentanyl. There are other opioids out there, but these are the ones that we're most commonly going to be using for our procedural sedation and analgesia planning. So these are drugs that have varying durations of action, varying levels of pain management, and varying side effects. And then we also have one more category that we look to as part of our procedural sedation and analgesia, and that's our dissociative, which is going to be ketamine. So we will have situations where we decide that this as an injection, as a CRI, some various options that we can use ketamine to make it something that makes our plan successful for the procedure we're looking at. So we've considered all of the drugs that we have available, and now we have to create our sedation plan. So when I'm doing this, I kind of look at different categories that my patient is going to fall into. So I think about, is this a situation where just an opioid will give me enough sedation and analgesia to get through the procedure that I have planned? The next one that I have, my second category, is going to be sedative and analgesic combination. So is this a situation where my patient is going to need more sedation, or the procedure is going to be long enough that I want to have some additional sedation on board? And so then I'm looking to a sedative and an analgesic combination. My last category is going to be sedative, analgesic opioid, and an adjunct. So this adjunct is going to be something like ketamine or alfaxolone being added to my sedative analgesic combination. This is going to be a situation where we have a patient who really just needs more than I can provide with the sedative analgesic combination. The one that I think of most often is when we have that cat that comes in who is giving us the side eye. We know that they're going to be pretty upset when we try to do this ultrasound, but they also have cardiac disease. They also have hyperthyroid. They also have kidney failure. So now I have an angry cat that I need to sedate, and I don't have a lot of choices available to me. So considering using an adjunct like alfaxolone in a situation like that can give us the ability to get those really good diagnostics, to get that really good ultrasound with being mindful of the comorbidities that our patient has. So things that I also consider when I'm looking at that category selection is, how is my patient? Are they painful or non-painful? And really thinking about what that looks like. So a young puppy that we're just doing radiographs on for something like an OFA, probably not painful. We could have an 8-year-old patient that's coming in, an 8-year-old Labrador that's coming in for radiographs. We might not necessarily consider them painful, but we now have an older dog that we're potentially putting on their back. We are putting them into a position where they may not be comfortable, and we have to consider that as part of our analgesic plan. We also consider healthy versus sick, and this is a situation where your young, healthy patient probably will take more drugs than your older, more compromised patient. So we have to consider that and what that looks like in our sedation planning. We also consider young versus geriatric. So when we're talking about very young patients or very old patients, they often don't require as much sedative or analgesic as a sort of normal aged patient, mid-aged patient, because they are compromised, and not compromised in that they are sick, but compromised in the sense that organ functionality is not the same for our geriatric and our pediatric patients. We're also going to consider temperament. And this is something that really can change what our sedation plan looks like. If we have a very scared patient or a very fractious patient, they will require potentially more sedative or heavier hitting sedatives to get the imaging and the diagnostics and the nail trim and the physical exam that might be required. Where a calm patient may need just a little bit of sedation to get those radiographs, to get that ultrasound. So really considering all of those factors when you're creating that plan. And then optimizing for positive sedation outcome. So you've decided to sedate your patient. You've gone through and you've considered all the comorbidities. You've considered what level of sedation you need. You've gone through all of these things. We want this to go well. We want this to be something that is positively reinforcing for your staff, so that this is something that becomes a habit and a behavior in your practice, where you're choosing appropriate sedation for your patients. And so then you look at this. We want to limit our potential side effects. So things that we can do that will help minimize and limit some of those potential side effects are to titrate to effect. And the thing that I always think is that it is easier to add than subtract. So if I am choosing an IM pre-med for my patient, I can always give a little bit more if I need to. But if I end up over sedating them, it's harder to take that away. And something to consider is that this titration can be a lot easier if you have an IV catheter. So if you have a patient that is sedate, place that IV catheter, and if they need a little bit more, giving an IV is going to make that a lot easier to titrate to exactly what you need. Minimizing stimulation is something that I do for every single sedated patient that I have. I will cover their eyes. I will use earplugs, and the earplugs aren't anything fancy. I just take some roll gauze and put it in the ears so that it muffles the sound, because we've all had a dog on the table that has had dexmedetomidine, and they seem completely non-responsive until someone laughs or says something loud or something gets dropped, and then that dog tries to rock it off the table. So using those earplugs can be a real game changer when we're decreasing some of that external stimulus. Keeping spaces quiet, keeping the patients padded appropriately. I always put a towel between the stifles and the elbows so that I'm keeping them really comfortable, making sure that they are as comfortable as possible on that table and really minimizing noise. And that can be hard because we work in busy spaces where there's a lot going on. And I'm not ashamed to be the person to ask everyone to turn it down a little bit, because I want to maximize that sedation. I don't want to have to give more drugs because people are loud. I also really focus on safety. And so I make sure that I have all of my supplies ready to go. And even if I get out things that I don't need, I'd much rather just put them away at the end than have to scramble and end up extending that sedation period. And I'm a pre-planner, so I pre-plan for every contingency. I always think about things that I might need and have those available. And then as part of this, optimizing for your positive sedation outcome, you should be planning to monitor your patients. This is not just sedation. We are altering consciousness. We are altering some of those vital parameters. So at a minimum, you should be using a pulse ox, monitoring temperature, and doing hands-on monitoring. Those are sort of your minimum requirements for monitoring. You should also be considering using non-invasive blood pressure. If you have half a second where you are concerned about the blood pressure, just grab your non-invasive and place it. You also can use your end-tidal CO2 monitor with a patient that is not intubated. So if you have them on an O2 face mask, you can place that end-tidal CO2 monitor on the face mask. It won't be accurate because they're not intubated, but it can give you some information about how well they might be breathing in that mask setting. If you have a pulse ox on and it is giving you a low number, we often will try to either blame the monitor or blame the drug and say, it's just the dexmedetomidine. And what I say in those situations is, if I give oxygen and nothing happens, then it probably is the dexmedetomidine that is, or the other sedative that is potentially confounding that monitor. But if I have a patient who is saturating at 92 or 93%, and I put oxygen on them and they go up to 98 or 99, then I know that they needed that extra support. And it costs me very little to put on a little oxygen to help those patients. So if I have a patient that is saturating below 95%, I put on some oxygen and see what happens. If you have concerns, you also can place an ECG. And this starts to sound like a lot of monitoring that we're doing for quote unquote just sedation. But my job is to safeguard these patients. And if they are not in 100% normal state of consciousness, then they need me there to make sure that everything is going okay. So I do my best to make sure that I am very careful about that. And I do consider those monitors for every single patient that I sedate because I want this to be a positive outcome. Thank you to DECRA for sponsoring this edition of Step by Step. For more information on procedural sedation and analgesia, check out vetfolio.com.
As with all drugs, side effects may occur. For use in dogs only, not intended for use in cats, not for use in humans. Avoid skin, eye, or mucosal contact. In case of accidental oral intake or self-injection, seek medical advice immediately and show the package insert to the physician. Do not drive, as sedation, loss of consciousness, and changes in blood pressure may occur. People with cardiovascular disease and pregnant women should exercise special caution to avoid exposure. Uterine contractions and decreased fetal blood pressure may occur after accidental systemic exposure. As with all alpha-2 adrenoceptor agonists, onset of sedation may be delayed or may be inadequate in some dogs. Do not use Zen-alpha in dogs with cardiac disease, respiratory disorders, shock, severe debilitation, that have hypoglycemia or are at risk of developing hypoglycemia or are stressed due to extreme heat, cold, or fatigue. Zen-alpha should not be administered in the presence of pre-existing hypotension, hypoxia, or bradycardia. Due to the pronounced cardiovascular effects of alpha-2 adrenoceptor agonists, only clinically healthy dogs, American Society of Anesthesiologists, ASA classes 1 and 2, should be administered Zen-alpha. Dogs should be monitored frequently during sedation for changes in heart rate, blood pressure, respiratory rate, and body temperature. Tachycardia may occur in some dogs after recovery from sedation. The following adverse reactions have been reported: diarrhea, muscle tremors, and colitis. Refer to the prescribing information for complete details or visit www.decra-us.com.